โอเคครับสวัสดีครับก็ขออนุญาตเริ่มก่อนนะครับจะได้ไม่เลทไปมากกว่านี้นะครับ Good morning everyone. So we will start the symposium supported by Merck. This will be related to the urothelial carcinoma, especially the maintenance treatment in the first line metastatic disease. Today we will have two speakers. One will be come with us as an online. I would like to introduce Dr. Enrique Grande. He's a medical oncologist and head of the medical oncology at the MD Anderson Cancer Center, Madrid. And he's an internationally recognized expert in GU cancer, which particularly in the bladder cancer. And he has extensive experience in the clinical trials and immunotherapy and also the precision oncology. And our second speaker is Dr. Pichai Jansiwong. He's a medical oncologist at Madrid Hospital, focusing on the genitourinary cancer, especially the prostate and urothelial cancer. So the first topic will be presented by Dr. Grande. It will be how Avelumab, as a first-line maintenance treatment, improve the balance between the efficacy and safety of urothelial cancer patients. Dr. Grande is now online with us, but the presentation will be recorded and we will start the video. Please.
Hello, I'm very happy to be here with all of you. My name is Enrique Grande. I'm chairing the program of cancer at the Quirón Salud Group. This is the largest private group that we have in Spain. I'm really thank you to the invitation that our colleagues in the region from Merck has offered to me, and I am delighted of being here with all of you today. So the task today is to talk about how Avelumab in first-line maintenance treatment offers a balance in between efficacy and safety for patients with advanced urothelial cancer. These are my disclosures, and I want to thank again Merck for the kind invitation. And let me briefly, take you through the guidelines. What guidelines are telling us how we should treat our patients with advanced or metastatic urothelial cancer? Well, we have a preferred regimen, and the standard of care so far worldwide is the new fancy combination of enfortumab vedotin and pembrolizumab, based on the data of the EV302 trial that offers an improvement in overall survival when compared with chemotherapy, platinum-based chemotherapy, but not only overall survival, the progression-free survival was also improved, and also the responses. The responses were amazing. Up to 2/3 of the patients will be responding, up to 30% of them will achieve a complete radiological response by RECIST criteria. However, worldwide, the access and reimbursement to enfortumab vedotin and pembro is not universal. As you know, probably you are aware that in your countries, the access is not the ideal one. And also there are patients that are not eligible to receive enfortumab, because of the expected toxicity with the drug. For those patients, platinum-based chemotherapy still remains one of the options. And if you need to go for platinum-based chemotherapy, you have two options to offer to your patients. The triplet, the combination of gemcitabine plus cisplatin plus nivolumab, and this is only focused for patients eligible to receive cisplatin according to Galsky criteria. And also we have the opportunity to give them gemcis or gemcarbo, followed by Avelumab maintenance for those patients that are not progressing during the induction chemotherapy. And this maintenance strategy with Avelumab, it is really impacting in the overall survival, contributing also to preserve the quality of life of the patients. We're going to get into details. If you are asking me, what is the best strategy, the best drug, the best combination, the best treatment for patients in first line with metastatic advanced urothelial carcinoma? I would say enfortumab vedotin and pembro. Because when you are asked about the best scenario, about the best efficacy, about the most potent option, you are always thinking about efficacy, about activity. But let me briefly show you what are the differences in between the three alternatives that we have to offer to our patients in first line. And the first thing that we need to acknowledge, we need to realize, is that the schedule of administration is completely different in between the three strategies. If you decide to go for Javelin Bladder 100, maintenance Avelumab, that means that you will give 4, 5, 6 cycles of induction Gem-Cis or Gem-Carbo followed by Avelumab maintenance. If you want to use the triplet, you go for Gem-Cis-Nivo for 4, 5, or 6 cycles followed by Nivolumab maintenance, as you can see in the slide. But if you decide to go for enfortumab vedotin and pembro, and you and your patient can afford to pay the cost of enfortumab vedotin and pembro, well, as you can see here, EVP, enfortumab vedotin plus pembrolizumab, will be given forever, or at least until toxicity is appearing. Once again, if you are looking for activity, go for EVP. Longer survival, longer progression-free survival, more responses, 30% of complete radiological responses by RECIST criteria. This is something unbeatable. This is something that is changing the practice. This activity has no precedent in the field of metastatic urothelial carcinoma. So definitely, guidelines are recommending EVP as the standard of care, but not all patients can receive EVP because of access, reimbursement, or issues with the expected toxicity. All right. However, we always, in the consultation at the clinic, we need to balance efficacy, activity, potency with quality of life, with toxicity, with what patients are really demanding from us. And this is why I think it is important to realize and to notice the differences in terms of activity and also in terms of safety profile of the three different alternatives. Why I'm saying that is because around 1/3 of the patients taking enfortumab vedotin and pembro will need to withdraw the drug because of the toxicity issues. 40% of the patients will have grade 3, grade 4 adverse events. When we are comparing these figures with only 11% of patients that needed to withdraw the drug with Avelumab maintenance, I think this is a major differences in terms of toxicity and tolerability. And this is easy to understand. At the end, new antibody drug conjugates, enfortumab vedotin, pembro, are extremely fancy, I would say extremely sexy, and everybody wants to touch these new drugs, and this is logical, and this is something that we all want in oncology. However, at the end, antibody drug conjugates are nothing else than fancy new chemotherapy delivery strategies. At the end, enfortumab vedotin is a taxane that is given intravenously. Take a look at this data coming from the EV301 study, the study with enfortumab vedotin as a single agent in the field of metastatic urothelial cancer that are progressing to chemotherapy and also immune checkpoint inhibitors. Well, take a look on the left. The highest is the dose, the highest will be the responses you can expect. But take a look at what you can see on the right. The highest is the dose, the highest is the toxicity you are expecting. This is something that we already saw when we were using chemotherapy. The most potent chemotherapy we have, the highest chances to respond, however, the highest toxicity we can expect. This is also true that we all want to offer this kind of activity to our patients. This is the median duration of response for those patients who achieve a complete radiological response by RECIST criteria. Median duration of response for this particular subset of patients, the patients with the best prognosis, the patients who achieve a complete tumor shrinkage, was longer than 2 years. However, take a look at what you can see on the right. The median number of cycles of enfortumab vedotin and pembro, despite the patients achieve a complete radiological response, despite the patients achieve the best tumor shrinkage that we can offer to our patients, despite the median duration of the response is longer than 2 years, the median number of cycles was only 13. That means around 10 months of treatment only. What happened to those patients? Well, enfortumab vedotin needed to be stopped or discontinued because of the toxicity. So enfortumab vedotin and pembro is changing the practice, is the current standard of care, but we need to learn how to use it. Because the toxicity, skin rash, hyperglycemia, and particularly the neurotoxicity can be extremely harmful for the patients, or at least it can deteriorate the quality of life of our patients. If you don't believe me, take a look at this video in which you can see a patient with a grade 2 neurotoxicity. And we are just asking this patient to put the papers from one side to the other side of the pen that you can see on the
Y ahora del otro lado.
and this is great. And you can see, okay, probably this patient can manage himself. Okay, same day, same patient, same neurotoxicity, grade 2. We are asking the patient to tie the buttons of the shirt. Do you realize the clinical situation of the patient? Do you really notice? Do you really feel that this patient can afford to live alone? Because if the patient has a very good family social support, that would be great. However, if this patient has no this kind of social support, maybe we are in an issue. We are in an issue because this patient probably cannot live alone. This patient is dependent of social support, of family support, of a care from someone. Probably this patient cannot dress himself, cannot wash himself, cannot do the cleaning up of the house, cannot do the cooking, cannot go shopping, by himself. So this is why I'm saying that this is always good, extremely good, to bear in mind the efficacy, the activity, the potency of the drug that we have, but at the same time, we need to consider the patient needs. We need to consider the toxicity that we can induce to the patient. Of course, I don't know what is the cost of enfortumab vedotin pembro in your countries, but in Germany, this is public. And as you can see here, we have not only the toxicity, but we have also the financial toxicity to bear in mind. I don't know in your countries, but a country like Spain cannot really afford to pay the cost of the combination of enfortumab vedotin and pembro for all patients in our country. So the thing is, should we give EVP for all patients? Well, if you are asking 150 oncologists in the US, what are they expecting from new drugs, new combination in first-line metastatic urothelial carcinoma, the oncologists, our colleagues, were extremely excited, as you can see there, in the overall survival. We want something better, something more active. We want improvement in the survival. This is what we want to. When we were asked, okay, and what about safety? This is okay. Okay, I will manage. I will take care of that. However, if we are asking same questions to 150 patients with advanced urothelial carcinoma to have a better survival, this is okay. But what they are really claiming, they are asking for, is to have better drugs, better tolerated drugs. They are afraid of the toxicity. So when we have in front of our consultation a patient with a metastatic urothelial carcinoma, we need to have into consideration many things before offering one systemic treatment. Of course, the efficacy that we are expecting, of course. We want better drugs, more potent, more active, induce responses, induce a complete radiological response, induce a longer progression-free survival, longer duration of the response, and of course, improving the overall survival, and this is great. But at the same time, we need to have drugs that are well tolerated, that are not deteriorating the quality of life. Despite of doubling the overall survival, despite of inducing 2/3 of responses, 30% of complete radiological responses, enfortumab vedotin and pembro is not impacting statistically in the quality of life of the patient. So social support, as you can see here, cost, access, patient preference, how far the patient is living from the hospital. Don't forget that with EVP, the patient needs to come to the hospital almost every week. Treatment duration, level of evidence in the guidelines are extremely important to bear in mind. Okay, what is the difference in between the clinical trials outcome, the pivotal trials outcome, and the outcome that we can expect from daily practice? So can we really translate the efficacy that we saw in the pivotal trials to the efficacy in our patients in the clinic, in the daily practice. And well, I think we have some data in that regard. Well, these are the expanded access program with and the real world experience that we have with Avelumab in first line. Well, more than almost 2,000 patients were treated in the real world setting. And as you can see here, and you can see in green, what we saw in the pivotal trial, in the Javelin Bladder 100 trial, is exactly the same. It resembles perfectly what we can really find or what we found in the first patients treated in daily practice. Patients with comorbidities, taking co-medications, patients with different social support, social access. I think it is important to have drugs that we can really expect exactly the same that we saw in the pivotal trials. However, when we have enfortumab vedotin pembro, probably because of the toxicity, the activity that we saw in daily practice, or at least the first data that we have from real-world evidence with the use of enfortumab vedotin and pembro, coming, of course, from the US, where they have a huge access to the drugs, is not that equal, is not that similar to the one reported in the pivotal trials. In terms of responses, as you can see here, it's not bad. 54% is not good, is not really bad, but this is not 67% as it happens in the pivotal trial, but 54% is good. However, the median progression-free survival in the trial was around 1 year, 12 months. However, here the 12 months progression-free survival was only 30%, and the 12 months overall survival was 67%, quite far from the median survival that was achieved in the EV302 trial of 33 months. So, probably because of the tolerability issues, probably because of our colleagues in the US are not using the schedule of administration, the official one of day 1, day 8, 1.25 mg/kg of enfortumab vedotin plus pembrolizumab, probably they need to reduce, they need to discontinue the drug more often because of the safety issues. So in the practice, can we re-identify patients? Well, don't forget that we have some risk factors in the first-line metastatic urothelial carcinoma, which are called the Bajoris risk factors. So particularly those patients with an ECOG performance 0 and a good performance and no visceral metastasis, the median survival will go up to 33 months. And also there are other patients with a deteriorated performance status with visceral metastasis that the expected median survival will barely exceed 9 months. In the real-world setting, the French experience, the Avelumab trial, is telling us that if we are able to select those patients that can benefit from the induction chemo, Avelumab maintenance, and when the patient progresses, when the tumor progresses, we can go in second line to receive enfortumab vedotin as a monotherapy. If we can select these patients in advance, the expected median survival can go up to 40 months. Unfortunately, the issue here is that we don't have biomarkers that can predict who will be those patients. But if we use the common sense, those patients are the ones with the better prognosis. Those patients are the ones with the better performance status and low volume of metastasis, particularly if they don't have liver metastasis or lung metastasis and they just have lymph nodes metastasis. So in the clinic, can we identify patients to enfortumab vedotin and pembro to select who will be those that will be responding and who will be those that unfortunately the toxicity will be an issue? Let's take a look at what guidelines are telling us how to identify patients for enfortumab vedotin and pembro. NCCN guidelines are still considering the Galsky criteria for it. ESMO guidelines, they are considering that if there is no issues in terms of access, availability of enfortumab vedotin, or enfortumab vedotin is contraindicated. But there are no formal contraindications for enfortumab vedotin, at least according to the EMA labeling. The EAU, the urologist guidelines, are telling us that in first-line patients should be candidate to receive combination therapy. But what it means, combination therapy? Because it means that the patient needs to have a ECOG performance status less than 2, creatinine clearance functions less than or greater than 30 milliliters per minute, and adequate organ function. This is the main reason because we developed the eligibility criteria to receive enfortumab vedotin. And initially, we were considering 5 of these factors. ECOG2, hemoglobin decoxylated above 8%, creatinine clearance function less than 45 milliliters per minute, any corneal or retinal abnormality, and grade 2 or higher sensory or motor neuropathy. If the patient had 2 of these 5 criteria, well, probably the patient, you should think twice before offering enfortumab vedotin because of the potential development of toxicity. Not because enfortumab vedotin is not going to be active. It's because of the potential development of toxicity. And these criteria were exclusion criteria in the EV301 and EV302 trial. So, okay, you can criticize this criteria. Okay, you are perfectly right if you want to criticize the criteria. However, we don't really have prospective data showing the activity and tolerability safety profile of enfortumab vedotin in this scenario. We ran a large worldwide survey asking colleagues across the world what were the main criteria they were considering in daily practice for not offering enfortumab vedotin. And take a look at this because I think it is relevant. There are 3 major criteria. If your patient has neuropathy grade 2 or higher, if your patient has a ECOG deteriorated status, ECOG 3 or higher, or the patient has non-urothelial component in the histology greater than 50%, probably this patient should not receive enfortumab vedotin. On top of that, and on addition of that, well, if the patient has corneal or retinal abnormalities, a creatinine and hemoglobin decosylated above 11%, severe skin disease, liver impairment grade 2 or higher, or need for dialysis, probably you need to consider twice before offering enfortumab to your patients. So to the question of, all right, so where would you position induction chemo followed by Avelumab maintenance? Well, I think this is very easy, at least in my practice. For those patients that are older than 8 years, I think the activity is preserved, is conserved. So induction chemo, probably carbogem for 3-4 cycles would be enough, and then switch to Avelumab maintenance. And of course, for those patients with non-aggressive tumors, those patients with lymph nodes only disease, those patients for which the ECOG performance status is not driven because of the tumor size. The ECOG performance status is driven because of the comorbidities of the patient. So if you have an old guy with comorbidities or the guy has only lymph nodes disease, well, probably this is the best candidate to receive the combination or the sequential strategy of induction chemotherapy followed by Avelumab maintenance. Can we do better? Well, I think we can do better with platinum-based chemo followed by Avelumab maintenance, and the way to do better is to diminish the number of cycles of chemotherapy before offering Avelumab maintenance. We know from the retrospective analysis that 4, 5, 6 cycles or even more cycles of chemotherapy is not really leading to a greater survival. So why do we have the need to push chemotherapy longer than 4 cycles? I think we don't need that. This is only increasing the toxicity without impacting in the activity. And this is the main rationale because we are running the DISCUS trial. 3 versus 6 cycles of induction chemo followed by Avelumab maintenance. We will be reporting this data, the DISCUS trial outcome, at ESMO in just 2 weeks. So hopefully we will see that by reducing the number of cycles of chemotherapy, we are improving the quality of life without deteriorating the overall survival, the progression-free survival, nor the overall response. Take a look at these different scenarios of the potential use of systemic treatment in first line. If you have a patient like this, a young woman, 58 years old, with a heavy and bulky disease, metastatic urothelial carcinoma, take a look at the size of the metastasis in the lung, take a look at the pleural effusion. Well, and if the patient has access to the treatment with the EVP, I think EVP is the perfect standard of care for this patient. I don't have any doubt. But if you have a patient like this, 72 years old man, with a good performance status, ECOG 0, ECOG 1, with a very small, tiny lymph nodes, retroperitoneal lymph nodes, why you need to offer for the most potent strategy? This patient probably with chemotherapy will smelt the tumor, will have a very good tumor shrinkage. And with the maintenance of Avelumab, this response can be durable in time. Can you make it very, very durable? So I think this is a very good option to offer for upfront chemotherapy followed by Avelumab maintenance. Why not? Or also giving a triplet. If you have a patient like this, 54 years old man, with these small, tiny micronodules in the lungs, of course, if you have access to EV-pembro, you can give the opportunity to, well, to achieve a complete radiological response, very long-lasting complete radiological response. But don't forget that only 13 cycles of EVP was offered to those patients who achieve a complete radiological response, 13 cycles, 10 months on treatment. If you have a patient, 54 years old man, probably with a mortgage, probably with sons or daughters under care, this patient needs to keep working. If you have a neurotoxicity grade 2, like the neurotoxicity that we saw in the videos, probably this patient cannot work any longer. Probably in the long term, well, probably the immune checkpoint inhibitor maintenance strategy with nivolumab after the triplet or with avelumab after induction platinum-based chemotherapy could be options. And if you have another patient profile like this one, 84 years old man, with this lung metastasis, all right, probably the ECOG2 is not because of this size of the metastasis. Probably the ECOG2 is because of the age and because of the comorbidities. Do you really think that a patient, 84 years old man, really needs enfortumab vedotin pembro, really needs the most potent and active activity combination? Well, probably single agent immune checkpoint inhibitor could be an option. 3-4 cycles of gem-carbo with low doses could be an option, followed by Avelumab maintenance. This is my last slide. Take a look at how the field is going to change shortly in the first-line setting. At ESMO, we will see a phase 3 trial with disitamab vedotin and an immune checkpoint inhibitor combination conducted in the Chinese population in first-line. And it is, because we know the press release, it is impacting in the overall survival for patients with HER2-positive tumors. We will have the new toxin conjugated drug like selenectide, pevedotin, the new competitor of enfortumab vedotin. In this scenario, probably it will have similar activity and probably with a reduced price. And I say probably because the cost of manufacturing is different for a toxin conjugated drug rather than an antibody that are more complex molecule. We have just seen the data of the Javelin medley. Probably there will be in the future combination of Avelumab plus ADCs as a maintenance strategy. We will see that. And of course, at ESMO, we will see the data of the Discus trial, 3 versus 6 cycles of induction platinum-based chemotherapy followed by Avelumab maintenance. Probably will give us some insights that it will improve the quality of life by diminishing the number of cycles of induction chemo by preserving the efficacy. Thank you so much for your attention. Thank you.
Thank you, Dr. Grande. And next will be the presentation by Dr. Pichai Chansiwong. He will present the provincial case sharing, which will be the EAP of the Avelumab in the advanced urothelial cancer. Dr. Pichai, please.
Thank you, Dr. Willow. I will share about the real-world experience of Avelumab in Thailand. That is the compassionate use from the Merck that provide for the patient in Thailand about 20 cases in 3 hospitals, in Rama Thibodi, in Philippines, and Chulalongkorn Hospital. Nowadays, we have the 19 approved cases that use the Avelumab, just one that waiting for complete the chemotherapy. 14 cases that's active ongoing with the treatment with Avelumab now, and about these two cases that's discontinued from the PD now, and 1 case is discontinued from AE. Mostly of the case is about more than 60, that the average is about 66 years old, and dominant in male, that we know about in bladder, and in bladder mostly in male. But in upper tract of in Thai is equal about male and female. The disease profile that we use mostly in the metastatic in stage 4 of the bladder and upper tract. And chemotherapy that we use mostly is carbogem, about 15 cases. 2 cases is the FISGEM and 2 cases is about the dose-dense MVAC. For the treatment, number cycle of the chemotherapy mostly about 4 cycles, and we have about 5 and 6. Just 2 cases of the patient that use about 3 cycles of the chemotherapy. For the response for the chemotherapy, mostly about the stable disease. Just 1 is complete response, and 5 cases is partial response. Only 1 that progress on the chemotherapy not eligible for the Avelumab. Nowadays, we have the free time from post the chemotherapy. Okay. Post the chemotherapy, we have the time duration about 4 to 6 weeks. Median time is about 4 weeks after the complete chemotherapy. Nowadays, we use about 1 year of the treatment, and the median duration of the real-world evidence in Thailand, we have about, when compared with the Javelin 100, is about 11.5 cycles. In Thailand, we are ongoing with about 13 cycles. I have sharing my case from the Madrid hospital. The first case is about urothelial bladder, urothelial cancer mixed with the squamous differentiation. That we know about the squamous differentiation is the aggressive variant and poor prognosis. But this patient used Avelumab and had the partial response and good tolerate with Avelumab. This case is 63 years old. He presents with about urinary retention, difficult in urination. In the first, we check about the PSA. PSA is good in normal level, but the rectal exam show about the heart and nodular prostate. CT scan find about the last lesion of the prostate urethra, about 5 centimeters. And have the effect to the rectum and anal area, and far about para-aortic and aortic lymph node enlargement. On November last 2023, show about we do the TURP and the pathologic show about the invasive urothelial carcinoma with squamous differentiation, and this case referred to my hospital. The urologist do the robotic assisted laparoscopic total pelvic exfiltration and lymph node dissection. The tissue showed about the poorly differentiated urothelial carcinoma with squamous cell invasion to the prostatic urethra and the bladder wall and rectum, bilateral femoral vesicle, and lymph node enlargement. The staging is T4, N2, and M1 by non-regional lymph node. The GFR on that time is good GFR. Treatment with the gem carboplatin 6 cycle and show about the stable response after the treatment with carboplatin, gem carbo. Start Avelumab, the dose is 800 mg Q2 weeks, start on September last year. Well tolerated and no side effect. The response of the target region is about the para-aortic lymph node decrease in partial response. The last imaging that we done in show about the continue about partial response. The lymph node nowadays is just only 0.7 centimeter, and the lung lesion is now the X-ray show about near restoration, no lung lesion now. And nowadays he continue about the Avelumab and no any side effect of that. In the second case is about the patient have recurrent lymph node, and this case get the CR response after the chemotherapy, and Avelumab show it's safe and good in the elderly patient. This case is 79-year-old and he have multiple comorbid. He have history of the desmoid tumor. But nowadays the reason of desmoid tumor no any symptom. in the abdomen. He had presented with the gross hematuria, and CT scan showed the mass in the bladder, enlarged of the right external lymph nodes and parietic lymph node. Staging is 3N2 and M1A. Start with gem carbo 4 cycle. After of the gem carbo, he have get the CR response. We start the Avelumab on October last year and still continue CR response. The last imaging on August show the CR response. That show we can use in the patient who have get the CR response after the chemotherapy. And the third case is about the patient who have the infusion reaction. We need to concern about unique side effect of Avelumab. But the data show just only infusion reaction, only the grade 1 and grade 2. We need about the specific pre-medication and concern about the infusion reaction in the fourth cycle of the treatment. This case is 17-year-old male, and he diagnosed with the bladder cancer on 2020. That show about the T3 and philo. Post the cystectomy, no adjuvant treatment on that time. 4 years later, he had the complaint with about the pain in about his leg. Bone scan show about the bone metastasis in the pelvis and cecum. The PET scan show about the lung lesion and the lymph node lesion. So he have the lungs, bone, and lymph node metastasis. Have bone pain about 6 points. So we consult the radiation treatment for palliative treatment. His GFR is just only 35, cannot afford about the denosumab that's not reimbursed in Thailand. We start with chemotherapy, gem carbo, about 4 cycles, and after that he have the stable response by the chemotherapy. February this year, we start Avelumab, pre-medication with CPM. The patient received about the paracetamol, but he not take the paracetamol because he think that's not necessary to do. On the first cycle, he had the fever during the infusion reaction, and so we check after that because the patient not take about the paracetamol. On that time, we hold about the Avelumab, but the fever resolved and continue Avelumab. For the second to fourth cycle, we start Avelumab by pre-medication with the paracetamol and CPM injection. No any fever after that. But after the fourth cycle, we continue like the pre-medication in the paracetamol and CPM after that. The CT scan show by the response, stable response in the lung lesion in the same as the previous CT scan. So the recommendation of the administration of Avelumab, that's unique side effect like infusion reaction. On the first to fourth cycle of the treatment, we start by the pre-medication, CPM, IV, and paracetamol 1 tablet, about 30 to 60 minutes before the treatment. Avelumab administration in the saline 250 ml IV in over 60 minutes. If the patient have about the grade 1, decrease the infusion about 50% and closely monitor. If we get 2, again, we do about the temporary discontinue until get 1. And mostly of the patient not about the grade 2 and grade 4. So Avelumab is nowadays in Thailand have approved in 3 indications. In the first, Avelumab approved in the bladder cancer and urothelial cancer, like the maintenance after the first line chemotherapy. The patient not progress on the chemotherapy. Second is RCC, that Avelumab have the study in the first line treatment of the patient in clear cell RCC combination with axitinib. And the third, Avelumab is approved in Merck cell carcinoma, that is neuroendocrine type of the skin cancer, found in mostly elderly patients. In Thailand, approved about the adult and pediatric who have age more than 12 years old. In post-hoc study of Javelin bladder 100 that show about, we think about the Nectin-4 expression, like in the EV. Again, Avelumab show in the efficacy in the both of the high and low expression of Nectin-4. About the mixed histology type that we found like squamous cell carcinoma mixed in the urothelial carcinoma. 20% of the patients in the Javelin bladder 100 have mixed cell type. That show in the frame about the who have the PL urothelial cancer and mixed type show the efficacy in the both in the same way. About the chemotherapy, about the gem carbo, gem fist, and those then MVAC look like in the same all respond with the Avelumab. So conclusion, Avelumab demonstrate about the effectiveness and tolerability in the maintenance therapy for the after the first line treatment chemotherapy. And real world evidence show about the acceptable safety and effectiveness of Avelumab maintenance therapy. Thank you.
Thank you very much, Dr. Vishai, for the presentation. And if anybody have the question for both speakers, please send the questions. I would like to start for the question for Dr. Grande that does the patient that have better response to the chemotherapy, we also have a better benefit from the Avelumab maintenance?
Well, good morning there in Bangkok. Thank you so much for the question. Thank you so much for the invitation. And to respond to the question, I think, yes, we need to offer for maintenance Avelumab, even in the best scenario for chemo, even for those patients that are reaching the complete radiological response by RECIST criteria. The duration of the response, the quality of the response that we can get with chemotherapy is not that durable. Even in the best scenario, those patients who achieve a complete radiological response, the median progression-free survival for these patients was only 4.8 months or 5 months. So that means that even in that case, even in those patients extremely sensitive to platinum-based chemotherapy, at the end, they are progressing very rapidly. So we need to consolidate the response by giving patients the maintenance Avelumab.
So in that case, should we try to give the better chemotherapy like a cisplatin-based, or maybe the dose-dense MVAC more than just the carboplatin?
Well, it doesn't really matter if we are using cisplatin, giving the standard GEM-CIS schedule or dose-dense MVAC. The duration of the response is not really depending on the number of cycles, on the intensity of the chemotherapy, rather than it is depending on the sensitivity to platinum-based chemotherapy. Hopefully soon, in just 10 days at ESMO, we will see the data of the DISCUS trial that is comparing 3 versus 6 cycles of platinum-based chemotherapy, including both carbo-gem and cisplatin gemcitabine. And you will see that there are no major differences in number of responses or duration of the responses induced by platinum-based chemotherapy in a prospective and head-to-head comparison trial. So this is not just a matter of platinum sensitivity. This is not just a matter of the type of chemotherapy or the intensity of the chemotherapy. This is just sensitivity from the tumor to the platinum-based chemo.
In Thailand, what is the incidence of elderly patients that have the advanced urothelial cancer, Dr. Pichai?
About the study in Thailand, we have no specific data. That's mostly of the patient in Thailand, about I think 60% or 70% is elderly patient and have the cisplatin ineligible. So the problem about the chemotherapy that cisplatin cannot use. I agree that Dr. Grande that the chemotherapy not maybe no effect to use in Avelumab, but another side when we think about the patient who cannot access to EV pembo or cis or nivolumab, the patient just only have access to the chemotherapy. We think about how to choose the better response rate by the chemotherapy. The studies show about the cisplatin is better than carboplatin. Those that MVAC may be the better choice by the evidence base now. but by the limitation of the patient that elderly or renal function impairment cannot use about the cisplatin.
So for Dr. Grande, what is the cutoff age? Do you have any like as a contraindications for cisplatin, and also the EV pembo?
That's a wonderful question. I think there is no clear cutoff age threshold, but I would suggest to use the common sense. I have patients 83, 85 years old that I am using cisplatin, and I have patients with only 68, 69 years old that I wouldn't use cisplatin at all, you know. I think this is a matter of using the common sense, eco-performance status, comorbidities, co-medication, social support of the patient are the drivers for deciding to go or not for cisplatin or carboplatin-based chemotherapy.
Since there are many of the ADCs not available in Thailand, so what is your actual practice after failing the first line chemotherapy and maintenance Avelumab? What is your second line of choice?
If EV monotherapy is not available, I think we are using vinflunin, taxanes. This is the standard comparator arm for the new trials, erdafitinib, enfortumab vedotin, or new antibody drug conjugates that are in development right now in this field.
So what is your practice?
Because by the limitation of the assessment that in the frame we use the chemotherapy after that. But if the patient if the patient can assess, we test about the biomarker like the FGFR to find out, or HER2 now that have the data of the ADC that's specific for HER2, but with a very small number of patients can assess about that.
Okay. Unfortunately, we run out of time. We have to, sorry to tell you that we have to close the session, and hopefully we will can have Dr. Grande in the near future come on site with us in TSCO future meetings.
Looking forward to it.
Thank you very much.
Thank you.
Thank you. Bye. Bye.